Good afternoon. My name is Colt Martin, and this is my final master thesis presentation for LED 699 for Professor Barnett at Colorado Christian University. Just want to take a minute just to thank you again, Dr. Barnett, for all your time and effort and wisdom you imparted on us as a class. It was really beneficial and helpful in us completing this program, but also completing this thesis. So, the thesis that I've came together with, and the title is The Benefits and Barriers to Implementing an Atrial Fibrillation Program. This is something that I have been working on the past year and a half within my Hospital Corporation of America in the West Florida division. We focused on the arrhythmia population, which includes atrial fibrillation, which is as high as percentage of patients within that class. So I really wanted to focus on working with the team within the hospital setting to implement the best practices and put together this program for the patients. So what is atrial fibrillation? Atrial fibrillation is the most common type of arrhythmia affecting over 6 million individuals worldwide. AF can lead to an increased risk of stroke, heart failure, and mortality. And hospitalizations have increased by 23% over the past 10 years in patients 65 or older. AF has increased the economic burden on healthcare institutions and by increasing the length of stay and readmission rates. And at this time, no national standardized programs have been put in place, and none are regulated by the government. The research idea: the number of Americans diagnosed with atrial fibrillation has multiplied over the years, but no standardized changes have been made within healthcare institutions. New medications, treatment options, and guidelines have been developed to manage and treat this disease, yet institutions have not made adjustments to their programs. Healthcare institutions must institute a standardized program to effectively manage and treat this growing population, and physicians must incorporate the most up-to-date treatment guidelines within their daily management strategy. The problem statement is AF patients are undiagnosed and mismanaged from onset of the emergency room through admission to the hospital due to a lack of quality standardized program. No identified programs have been recognized regarding identification and treatment of AF patients within our healthcare system, leading to a potential increased risk for stroke and high readmission rates. So what is the purpose for doing that? Evidence-based guideline management within disease processes have been out since the mid-1900s. An evidence-based practice is an explicit and judicious use of current best evidence in making decisions about the care of individual patients. That was from Picardi and Masicki 2014 study. The American Heart Association, the American College of Cardiology, and the Heart Rhythm Society are the governing boards for this cardiac disease. And in 2014 came out with the guidelines for management of patients with atrial fibrillation. These best practices were structured around 85 different trials that included over 30,000 patients. Many of these were randomized studies. Some were retrospective data, others were case studies, and we'll go into that in a little more detail. One of the most important things with atrial fibrillation patients that I discussed is the increased risk of stroke. The societies came up with a risk stratification tool. It's called a CHADS-VASc and a HASPLED, and that's what we're using and built within our system to decrease our patients' risk of stroke by doing the score and getting on proper anticoagulation. So as we built a team within the hospital, we wanted to assess what was our gap, what was the reasoning for the lack of implementation of evidence-based guidelines within our healthcare institutions and within our physician practices. And studies within the United States and Netherlands suggest that at least 30 to 40% of patients do not receive care according to current scientific evidence. And that's with Patel, Deschmet, and Pont, and that was 2014 study. And what it really showed was the physicians felt that it impacted their workflow. The physicians had a lack of knowledge in the evidence-based guidelines. Many of these are internal medicine or family practice, And evidence-based guidelines are really focused on subspecialties such as cardiology and electrophysiology. Implementation costs and resources. Many physician practices are already regulated in their reimbursement, and so that lack of reimbursement falls over to a lack of resources that they're able to have within their offices and also the healthcare institutions. Currently, there's no negative impact by government regulations for not instituting evidence-based guideline and best care practices for patients within physician practices and organizations. And lastly is physician rebellion, and that was from the Poon study from 2004, just to really assess that physicians don't want to be told what to do. They want to make the decisions for their patients. So what did we have to do to implement this program? It was fivefold going through this organizational leadership class and program, really focused on really 5 strategic areas, and that was leadership, communication, trust, culture, and data abstraction. So leadership is key, and transformational leadership is essential in helping change the culture, opening up communication amongst the physicians and administrators and even the patients to really get best practices put into place. And you're only going to do that by showing the data. And we were able to look at quality metrics surrounding length of stay, the healthcare costs, the readmissions, complications, and the quality of life for these patients. So we did a 3-month retrospective study on the AF patients that came into one of our specific facilities, gathered that data, and over the past year that we've been implementing this program, we've been collecting the data on the patients with the new program in place. And I'll touch on that in just a few minutes. So the AF program within HCA, we really focus on a multidisciplinary, collaborative team approach. And we identified key strategic areas, and that was with identifying patients when they came into our hospital, putting together treatment and management flow charts, and also order sets, and these were based around the evidence-based guidelines. Educating not only the staff and physicians, but also the patients and community on the effects of atrial fibrillation and the treatment methods available. And then lastly is patient follow-up and transition of care. And this is really where you focus on the readmission rates and decreasing those, but also making sure that the patient is properly educated. And as I stated before, data-driven. We really looked at length of stay, risk stratification of patients for stroke, and the readmissions. So we put together a strategic plan that with the collaborative team of physicians, administrators, and staff. And we focused on a single site at first, and that was so that we were able to use the necessary resources and track each individual patient. Data abstraction focused on length of stay, readmissions, and stroke reduction, complications, procedures versus medications, quality of life, and patient follow-up. And the implementation really was obtained through a transformation leadership model, a change in physician culture and behavior, open communication, problem solving, and weekly meetings. The focus for this program was shifting from an inpatient model to an outpatient management and treatment strategy. And that was to reduce the readmissions, but also get specialist involvement and reduce overall healthcare costs. This focused on reducing patients' length of stay. As I stated, I'm not able to publish the data because it's from HCA. I will have to look into IRB study so that I am able to publish the data. So guideline-driven care and then time management. The quality of life was focused on identifying stroke risks and appropriately anticoagulating patients because AF patients are 5 times more likely to have a stroke, and the strokes that AF patients have are the debilitating strokes. So that increases the long-term healthcare costs. And assess functionality scores. And the other is physician engagement. You need to build a relationship and trust with the physicians so that they get the buy-in for the program, as well as showing them the data so that you can make effective change. They need to have a performance measures. They need to know what they need to meet. You need to give them some sort of direction on key quality metrics that they're not making and that they can drive change with. And lastly is incentivize the physician. So the methodology for this program was a non-experimental approach. Through existing data, we did a meta-analysis over various studies. There's the Kalila 2013 prevalence of AF in the U.S., Patel 2014 trends of hospitalization in AF, and then January 2014 the guidelines for management of AF. We also assessed surveys. UBINC 2012 focused on implementation of evidence-based guidelines, and the Moscow 2005 survey focused on physician awareness and adherence. And then case studies were also analyzed, focused on treatment strategies of AF patients. So the results, as I said, I'm not able to share the specific data from the hospital that's 1 year out, but I am going to focus on putting an IRB study in place so that we're able to publish the data nationally. The data does show strong support for implementing an AF program within healthcare institutions because it does decrease the length of stay, lowering healthcare costs, and increasing the quality of life for the patients that we saw within that year of implementation. So in conclusion, evidence-based guidelines are beneficial in management and treatment strategies. They're a financial benefit to physicians but also healthcare institutions, and they've been tested through various randomized trials by the American College of Cardiology, Heart Rhythm Society, and the American Heart Association. The barriers are additional resources and costs.